based on the evidence that you have in this review, do you see liquid biopsy as something that's going to be a standalone tool for patients, or is this something that really needs to be interpreted in the context of other things like advanced imaging, biopsy, et cetera, that help us? Is it just part of the puzzle, or is it the whole thing, I guess, and where do you see things headed, especially with things like artificial intelligence and combining this with that? Where do you see the future of this?
And those are great questions. And I guess for that, I would bring into perspective stage 4 disease or metastatic disease, where I think so ctDNA has or liquid biopsy has the highest potential. I presented as an oral presentation last year at KCRS, which is the Kidney Cancer Research Foundation conference last year in Boston, where we looked into exactly this hypothesis. We wanted to see how can liquid biopsy, what's the role of liquid biopsy here? Can it be used as a replacement or is it more as a complementary? And what we found was that there were many there were many particular individual mutations which were found through ctDNA, which were not even found in tissue in the same patient. So we used the data from a matched patient cohort who had tissue biopsy as well as liquid biopsy. And many of those patients were able to see some targeted mutation in ctDNA. And we went and looked into tissue and those were not present. There were lots of mutations which were present in both. But what I'm trying to deliver is that it gives me some idea and gives us some idea that is more kind of complementary rather than completely replacing. At this stage, we are still not at this current time. I don't think so. We are at a stage where liquid biopsy can completely replace tissue biopsy. But if we are utilizing it as an extra tool, it can give us way more information in identifying individual patient risk.
Yeah, really, really interesting stuff. I mean, I think it is worth highlighting that the vast majority, if not all of the studies included in your review are small, right? We're talking like less than 100 patients in most of these studies. And what I'm hearing you say is actually what we need is more data. We need like larger data to help, one, improve the liquid biopsy itself, but two, improve our understanding of how to use these and how reliable they are in a lot of these different scenarios.
And
So that kind of leads me into my next question in that, well, shoot, if we're going to get more data, we need more people using it. We need more people reporting on this. We need larger studies of its utilization in practice. What is prohibiting its mass uptake in clinical practice right now? What do you see as the real barriers to using liquid biopsy today?
so, and to your point, I would just like to add that, yeah, all the studies with the smaller number of patient population, amongst them, majority were just stage 4 disease. And in most of the studies, wherever we saw benefit, in our review, we had divided again into 3 sections. And all those sections, the major benefit was found in later stage disease or metastatic disease. So I think so the major barriers is standardization. So a lot of this ctDNA or CTC assays platforms are kind of pan-solid tumor based. There isn't any particular standardized protocol for just RCC itself as well. Second thing is, again, there isn't enough information. So there's the utilization is in a similar way, like as we were discussing those case scenarios. Now I have this information about ctDNA that it has gone up or gone down. What to do next? It is just going to help me understand and maybe predict a little bit earlier, but I cannot act quickly on it, or I cannot make any immediate clinical decision unless I'm discussing it in tumor board and everyone is agreeing to it. So those kind of situations make us still utilize ctDNA less. More and more liquid biopsy platforms are now being reimbursed through insurance. However, sometimes if patients do not have those particular insurances, the cost of liquid biopsy is significantly high and probably a few $1,000s. And then again, I would highlight one more thing. So there's another platform which is coming up as well, where they are looking into ctDNA plus ctRNA. And it shows that when you combine ctDNA with ctRNA, you detect more fusions. And that can help us understand and identify more targetable mutations as well. This study was done in non-small cell lung cancer and not in RCC. But again, that data makes us again more question what platform to use. So there are so many questions which are going on, and that makes medical oncologists or many other different fields question when to use and how to use. But to your point, if we will use it and if we'll have more and more data, then we'll be able to formulate all these hypotheses and test them as well.
Really, really fascinating stuff. I'm gonna end our conversation by circling back actually earlier to talking about kind of the different forms of liquid biopsy, because in your review you talk about methylation being perhaps a really important thing in RCC. Can you talk, do you think that's the way to go with RCC, or is ctDNA the cat's out of the bag with just ctDNA? That's where it's going to be. Methylation is going to kind of go by the wayside. Or should these methylation specific DNA tests, should we invest more in that? And if so, is how much uptake is there in that as opposed to ctDNA?
So methylation is a very interesting aspect of this whole liquid biopsy as well. Again, lots of studies have just looked into methylation. It makes us, sometimes it has also shown that it has some association with histological analysis, or it can tell us like, yeah, it was found more in clear cell renal cell carcinoma as well. Along with that, methylation can also predict outcomes in a little bit more sensitive way. It can give us some data of aggressive tumor. But to your question, whether it is completely different, whether it can replace, or whether we can just focus on this, I guess more importantly, we need to just focus on overall the entire liquid biopsy, as a full circle, and rather than dissecting each of it as of now, because we are still not sure what's like at what stage and what to be focused more on.
Great point. Yeah, really, really makes a lot of sense. And right now, I think we're casting a broad net so we can narrow in the future. And I think it's really, really exciting. I think when you combine this with a lot of the technology we're seeing in imaging and also artificial intelligence, I mean, the future looks, for the first time, I think in a long time, like individualized medicine is a reality, whereas opposed, it's, I think for a long time, it's just been something we talk about and we have very little tangible things to help guide that. So
This
I,
year, at ASCO, there were like so many studies which were focusing on artificial intelligence identifying biomarkers. And those biomarkers, when they're combined with liquid biopsy, the outcome can be even better. So radiomics, along with that ctDNA and artificial intelligence can probably make wonders. One more thing I really want to highlight. So with ctDNA, it can also give us information about tumor mutational burden, so TMB, along with that the allele frequency for TP53 as well. All this information can be extremely helpful in identifying patients for clinical trials as well. So liquid biopsy, along with helping in clinical decision making, it is extremely helpful. And now it's almost becoming part of lots of protocols in clinical trials, whether it's phase 1, phase 2, or sometimes phase 3 as well. And as we would see in all the different grants when we apply for, there's a particular section for correlative studies or biomarker studies. Liquid biopsy has a great role at all these places over here. So the future for liquid biopsy is quite bright, and we still need to continue doing multiple different projects and researches, whether it's translational bench to actual clinical portion, and that will give us way more information on where to utilize it.
Chinmay, really, really great work. Really enjoyed talking to you. Appreciate you taking the time, and congratulations. I look forward to seeing much, much more from you in this space in the future.
Thank you so much. Thank you so much. One thing as an endpoint will be just at least for stage 4 disease and metastatic disease, consider doing liquid biopsy whenever you see a patient diagnosed with it at the diagnosis itself, because it will give us information about targeted mutations, tumor mutational burden, and total mutation will help us understand the risk factor, recurrence, and prognosis as well.
Couldn't agree more. Take home message here is we need more data, use it, and so we can learn more and figure out what's going on here.
Exactly.
Thanks so much, Chinmay. Appreciate it.
Thank you.